Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we have another great show for you tonight, and I want to talk about childhood asthma. This is an asthma series. We had a show that we concentrated on adult asthma, but children and asthma is a definite problem in our country. It's increasing in numbers, and I want to go through it in detail today so that you will understand if your child has asthma, exactly what you need to do. Well, before we get to the topic, let's talk about caring and sharing, my favorite two words. Remember, caring. And what I mean by that is that we care for each other. So let me know what's going on out there. We can email each other. You can email me at www.medmoments.com or tweet me at medmoments, and we'll communicate. Let me know if the shows are if they're in the right direction as far as your health is concerned. Remember, you know what a med moment is. I've talked about it. A med moment is that moment in time or space when something happens that you know you got to go to the doctor. That chest pain when you walked up the stairs, or that knee pain that just won't go away, or want to lose weight but you just can't figure out how to do it. Those are med moments, and you need to see your doctor, because if you can take care of those, then you're taking care of your health appropriately. And it's all about that. It's all about good health. It's all about coming together and seeing if we can live longer in a better way. Okay, so let's talk about childhood asthma. Tonight, I have the perfect person to talk about this particular topic, Dr. Kendall Sprott, and he's a Senior Associate Dean of Clinical Affairs at Rutgers, New Jersey. All righty, Dr. Sprott, welcome to our show.
Thank you.
All right. The thing of it is that childhood asthma, it's a problem that's just too common. And I want to start off with my first question, my usual first question. What is childhood asthma?
Well, asthma is a disease that's found in children and adults, and it's a disease that involves chronic inflammation of the airways.
All right. Now, we're going to break words down. Inflammation. When you say inflammation, what do you mean by inflammation?
Well, inflammation is a complex of about 4 different things. And when you talk about inflammation, a lot of times it refers to a specific part of the body, and the last 4 letters that are attached to that part of the body that's inflamed are ITIS. So anytime that you have ITIS at the end of a word, it indicates that you have inflammation of that part of the body. So if you have arthritis, that itis at the end of arth means that you have inflammation of the joints. You have otitis, the ear. You have inflammation of the ear. Bronchitis, inflammation of the bronchi. And very often, many people who have asthma will say that they have bronchitis. They don't have asthma. And so when we talk about inflammation, the 4 things that are associated with inflammation are redness, warmth, swelling, pain, or dolor, the Latin terms that we learned in medical school that describe it. And then if you're talking about a 5th term, usually you're talking about a function or a decrease in function of an area. So when you have that complex of something that's warm, red, hurts you, and is swollen, you're pretty sure that inflammation is something that's going on.
Okay, all right. Now, with all these different things that you're talking about at this particular point are happening in the airway?
That's correct. So remember that the airway are those parts of the lung that are the path through which air moves in and out of the lungs.
Right.
When you're talking about the lungs themselves, the lung that expands is not the airway. It's at the end of the airway. And the ability for the air to move in and out of the lungs is really related to the size or the diameter of the airway. There's a certain problem that is involved in the movement of air related to the size, so that if the size of the airway decreases, the ability to move air in and out of the lung becomes compromised.
Okay.
And in children, even in adults to a certain degree, the size of the airway changes slightly when you breathe air in versus when you breathe air out.
Right. Now, let's just think about it this way also. As far as children is concerned, is there a difference in how the airway is constructed or put together or is affected by asthma depending on how large you are? Meaning a baby, a very small baby, like an infant, as opposed to a teenager. Is there a difference in how asthma affects the airways or how the patient responds to these spasms that's occurring in the
So
airway?
the way that asthma works is asthma affects the size of the airways and makes them more narrow.
Right.
And so if you think about children versus adults, children are smaller, and so the airways of a child are smaller than the airways of an adult. And so very often when you talk about what's happening to the airways with asthma, a lot of people say, well, when I was a child I had asthma, but as I grew older I grew out of asthma.
Right.
That may or may not be true. Understand that when you're very small and your airways are very small, it doesn't take but a little bit of swelling or narrowing to occur to have problems. But as you get older and the airways get bigger, even though they are smaller, they may be large enough so that you don't have the same kind of symptoms or the frequency that you had when you were smaller. But a lot of adults who had asthma as a child continue to have asthma as an adult, but their symptoms may be milder or maybe even not symptomatic.
Okay. Tell me about parents and a child that has asthma. You know, if you have an infant and you're a parent, how do you know when to be alarmed? You know, you may see your child coughing a little bit. You may see them maybe look like they may be having a difficulty as far as breathing is concerned. But how do you know when it's time to, say, go to the emergency room or call the doctor as a parent? That must be just a tremendous anxiety there when your patient, if they think their child is having a problem breathing.
So a patient that has asthma, remember that I said that the airways being narrow makes it difficult to get air in and out of the lungs.
Right.
And it's more difficult to get air out of the lungs than it is to get air into the lungs.
Right.
And very often when the airways are narrowed, when the child breathes out, there may be a sound associated with it that's called wheezing. And so wheezing is a sound that's usually heard when the child is breathing out that indicates that the airways are narrow. In addition to the fact that there may be a sound, because the airways are narrow, the amount of air that's moved in and out of the lungs with each breath is smaller. And so to sort of compensate for the fact that you're not moving in the same volume of air with each breath, the child breathes faster. So that the normal respiratory rate of a child is going to be, you have to pay attention,
Right.
Might be 20 times a minute or so.
Okay.
But if the airway is narrowed and the volume is decreased by half, then in order for the child to move the same volume of air, the child would breathe at 40 times a minute. So there'll be a big difference between breathing at 20 times a minute and 40 times a minute. So a child that has asthma is going to be breathing faster. The child may have a wheeze, and the child may have difficulty in terms of moving the air, and may use muscles that they don't normally use in order to move the air in and out. So the child may have retractions. The child may have flaring of the nose. All of this is an indication that the child is struggling and working harder to move air in and out of their lungs. So there are several things that will be occurring at the same time, and the child will appear to be in some degree of distress.
What about colds? I mean, kids catch colds all the time. They're in school, they're catching colds, everybody's spreading their little germs. Will that affect a patient that has asthma?
So, as you know, there are a number of things that if you have asthma can trigger an attack.
Okay.
And in children, the leading cause of an asthmatic attack is a viral upper respiratory tract infection.
Upper respiratory. You mean
A cold.
a cold
okay?
or something
So
like in
when
the
we talk
nose
about
or
the upper
throat?
respiratory tract, we're talking about the nose and the throat and this upper part of the airway,
Right.
the trachea, which is sort of goes above in the neck and down into the thorax or the chest. So when we're talking about a cold, that cold usually means that there's an infection due to a virus that likes to invade the cells that are in the nose and the throat, and sometimes in the lower part of the airway.
Right.
Now, almost everyone that has a cold is going to have a cough. Coughing is something that is almost always present in a patient that has asthma. There are really two reasons that you cough. One is if you have an irritation in your throat area, and that'll be a cough. And that could be irritated because of an infection that's there and causing, again, that inflammation. You could say, that sore throat, pharyngitis, inflammation of the nose, You could have tracheitis or laryngotracheal bronchitis, or you could have, a nasal inflammation. But there's also a certain amount of production of mucus. And normally mucus is present in the airway, and it helps to trap things, particles that might be going down the airway. But you can have a postnasal drip that irritates the back of the throat. And so anytime you have an irritation in your throat, you'll have a cough. But the other reason, and this is the major reason in an asthmatic, is that you need to keep your airways clear. And when you have asthma, the mucus that's normally made and moved up the airway out into the throat area gets blocked and gets accumulated. And very often, because it's blocked and it starts to accumulate, the person that has asthma will be coughing to try and clear that mucus from the airway. And very often in children, when they cough, they don't spit the mucus out, they swallow it. And very often, if they accumulate enough mucus that they swallowed, they'll throw up. And when they throw up, you'll look at what they vomited, and you'll see there's a lot of mucus that's there. So many asthmatics, the only symptom that they may have initially is just a cough because of what's going on in their airways and an accumulation of mucus. And they may have trouble clearing that mucus because the mucus gets caught as it tries to move up and out because the airways have narrowed, and some of them have actually get blocked off.
What are some of the other triggers that we may think of? I understand like change in weather may be a trigger, or pollen or things like that. Do most asthmatics, are they affected by these triggers, or only certain asthmatics will, be affected by this?
So each asthmatic is different, although if you look at the statistics in children, the most common trigger in children, upper respiratory tract infections, are colds.
Right.
The second most common trigger are going to be allergens. And allergens are going to be things, proteins that the patient might be exposed to that might trigger the asthmatic attack, which means that the airways may be narrowed. And the airways could be narrowed from swelling, from the muscle that surrounds them constricting. Those are the spasms you mentioned. And the third is the increased accumulation of mucus. So all three of those factors will contribute to why the airway is narrowed. So when you're talking about an allergy, in many people, they are going to have seasonal allergies. And so if they have seasonal allergies, it's going to be in the fall and in the spring, like this time of the year,
right,
when the trees are blooming and the grasses are getting cut, and you'll see that it looks like dust that's settling on the cars.
Right.
Those are all things that are in the air. And so if you're allergic to dust, you're allergic to grasses, you're allergic to tree kinds of things, when those things are out and about, then you'll have trouble wheezing. You'll have sneezing possibly as another component. Sneezing is usually something that's very common with allergies. But when you're talking about allergies, it may not just be the airways that are involved. Most of the people that have allergies and have asthma, in addition to having the issue in the lungs, they're going to have allergic rhinitis, allergic conjunctivitis.
Okay, so these are big words that just went past.
Okay.
Rhinitis is
So
Nose?
rhine is the nose.
Right.
The itis always means inflammation. So
right.
rhinitis is inflammation of the nose.
Right.
Conjunctivitis, there's a thin layer of tissue both on the inner part of the lid and on the surface of the eye,
Right.
called the conjunctiva. And when it gets inflamed, they call it conjunctivitis. The common term is pink eye. So the point I was trying to make is that the people that have these allergies, that have asthma, if that allergy is there, it won't just be the lungs that will be symptomatic. They'll have the rhinitis and the conjunctivitis usually at the same time. So they'll have runny nose, they'll be sneezing. And so sneezing usually is going to be another component that shows that it's allergy. But not just allergy, there are irritants that could be in the air like pollution or cigarette smoke. And you mentioned cold, the change in the weather. Usually it's just exposure to cold air itself in some folks that will trigger their asthmatic attack. If they're inside and it's warm and they go outside, they'll start to cough, they may start to wheeze. In children, another factor that might cause them to wheeze is exercise. It's something called exercise-induced asthma. And so a child that's normal, you see that they start running around, all of the time they start to cough or they start to have rapid respirations or they start to wheeze, they may have exercise-induced asthma. Some individuals, if they're stressed, stress alone sometimes can trigger asthma. So it can vary from individual to individual what their particular triggers are. You know, if you happen to be allergic to dogs or cats or the danders, or to, you know, the protein from the excreta of cockroaches or mites, those allergens can trigger the asthmatic attack. If you're not allergic to a dog or cat, then exposure to a dog or cat won't trigger the asthmatic attack. So each child ought to be evaluated to see what their triggers happen to be, because if it's allergens, if you can avoid exposure to the allergens, you can prevent the attack. Now, at this time of the year, you know, unless you're in a bubble, you go outside, you're going to be exposed, and you need to be, you may be symptomatic, and then you have to get into how do you prevent the attack, or what treatments might there be to deal with, you know, reversing the symptoms.
Right. What about genetics? If mom or if grandma had asthma, is there a possibility that that would increase the chance of your children having asthma going forward?
Absolutely. So asthma is one of the diseases or disorders that has a genetic predisposition. And so the other issue that sort of goes along with asthma, allergy, is another condition called eczema. And eczema is dry skin. And very often when I see babies, and I see that these babies have dry skin or have eczema, I start to look to see whether or not they're going to develop asthma. And if they start to wheeze at an early age, then I start to think that the combination of this eczema, which implies allergy, also implies that they may develop asthma. And very often you'll find that many of the adults that have asthma had eczema as a child. And so certainly if you have family members that have asthma and you have a child that wheezes earlier, then you start to suspect or give the parents a warning that even though it might not be asthma, because the old saying, everything that wheezes isn't asthma, is certainly so. But if you got a strong family history of it, and then a child starts to have these associated signs and symptoms, it's very likely that they're going to have asthma.
Let's talk about, we know that babies have asthma, and as the kids get older, the school and asthma and the quality of life for the children. What can we do to help those children with asthma to see if we can give them a better quality of life, to see if we can prevent them from having days off from school? What can we do to just help those children as far as their airways and their breathing so that they don't have the asthma attacks, do you think?
Well, you know, asthma is a fairly serious condition, but how bad it is in any child can be variable. Okay. And so someone might have mild asthma, or might have moderate, or might have severe asthma. And a lot of this has to do with how frequent they have symptoms and how bad they are when they have the symptoms. So one of the things that you try and keep track of is how often are they symptomatic? Do they have symptoms every day? Or coughing. And as I said before, some patients only cough. And so you say, do they cough at night? How often do they cough? Does it disturb their sleep? Do they miss school? Asthma is the number one reason that children miss school. And very often when they miss school, especially when you have single parents, the mother has to work. If the child has to take off, can't go to daycare, can't go to school, then mom has to stay to school. So it's a tremendous burden on the economics of not only that family, but also of society in terms of days that are missed. And so the goal would be to start to look at the symptoms of the child, especially when they're mild, and try and prevent them from getting worse. And so what we do is we have different medications, and we have different ways, depending upon how old the child is, to see whether or not the asthma is quiet, getting worse, and hopefully before it gets bad enough that they have to miss school, you can start to use medications to try and reverse the symptoms. And it's easier to reverse symptoms when they're mild than it is when they're wheezing and have to go to a hospital. So if you can sort of understand that a child is starting to become symptomatic and use the right medications to reverse it, then you can prevent the child from missing school. And very often, if someone has the diagnosis of asthma, there's a legal requirement that the doctor develop an asthma action plan that has the medications that the child ought to be using as the child goes from mild to increasing symptoms, and very often either adding medications or adjusting the dosage of the medications might be able to assist and prevent the child from getting worse. And it's always better, as I said before, to start to use the drugs and change the medications when the child's not so bad, before the child actually has to wheeze and either miss school or have to go to the emergency room.
All right. Let's talk about a child and his relationship with his peers because he has the asthma, possibly being teased at school, possibly feeling depressed because he can't get out and run around with the other kids. How do we handle that as parents, as physicians, to really get these children to understand, where they are with their disease and how we can help them?
Well, I think it's very important for the parent and the child to understand that they have a condition and that the severity of it can be lessened and you can control the symptoms. So that there's no reason why a child that has asthma with the proper management can't be as active as any other child. But it requires that if you have exercise-induced asthma, that you take medication half an hour before you do the exercise. And if you do that, then you can exercise as well as anyone else. And because you have an asthma action plan, then the nurse at the school knows, okay, this person has to take an inhaler half an hour before they have exercise. And if you then follow the asthma action plan by increasing the medication when it needs to, then the child won't have that. There are many, many professional athletes that have asthma. Asthma is very, very common, but those individuals understand how to maintain and control their asthma by the proper use of medications to prevent them from becoming sick.
Right. We're starting to get to the end of our show. I just want to connect with a few things. Certain races seem to have an increased chance of developing asthma or having asthma than others. Is there a reason? Can you give us what we should look at as physicians or even as patients? What particular cultures?
African Americans, Latinos tend to have higher incidence of asthma. Lower socioeconomic groups tend to have more incidence of asthma.
Right.
And the question is not just what is the incidence, but whether or not those individuals are getting treated properly or have the right medications prescribed and frequent enough. Because in many respects, one of the treatments to help control asthma is the use of steroids, inhaled steroids. And many folks don't like the idea of steroids. They think that, you're going to have all sorts of problems and complications, and that's true. But with the inhaled steroids, the amount of steroids that are taken is a fraction of what you take when they're via inhaler than when you have to take it by mouth. Right. And when you take it by mouth, it's distributed all over the body and can have a higher incidence of those complications. But when you use the inhalers and you use a spacer, because a spacer is very important to get the proper amount of the medication in the lungs where it needs to be, not in the nose and the throat, then the parents don't need to have the fears about the use of steroids, which is a very, very important aspect of controlling the asthma.
Right. Now, as far as patients, like you said, blacks and Hispanics, is there an increased chance of them going to the emergency room or being hospitalized because they have more frequent asthma? Or even deaths, I know it could be increased.
So the answer is that all those things you said is true. Whether or not it's because they have it more frequently or not, or the attacks are more frequent, I'm not sure. I don't think that an African American or a Latino that has the right medications and uses the right medications appropriately ought to have a higher incidence of hospitalizations or emergency room visits. Very often it has to do with access to a doctor, either seeing the doctor to say you need to adjust the medication, or having a phone call to access the doctor, or an email, or something where the doctor is able to communicate. Very, very often, if you're poor, your access to medical care isn't the same as it is in the suburbs. And so it may have to do with how well you're controlled, as opposed to what your genetic makeup is.
All righty. We're going to have to end right here because the show is coming to a close. Dr. Sprock, thank you very much for coming in.
No problem.
And being on the show. In closing, all righty, remember, sharing and caring, www.medmoments.com. Email me. Look forward to hearing your emails. And tweet me @medmoments. Remember, never institute any change in your medical care until you talk to your doctor. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.